Hello, everyone. Welcome back to our podcast. Today, our guest is Breck, and he's the founder of ServRx. To start us off, can you share a little bit about yourself, Breck, and the company?
Sure, happy to. Yeah, Breck Rice, been around community pharmacies now for over 20 years, mainly on the revenue cycle management, helping community pharmacies get fair reimbursements they deserve, and co-founded the ServRx program about 12 years ago now. I love the industry, try to help community pharmacies be more profitable.
Yeah, you had a very interesting, I would say, like entrepreneur journey. Can you tell us a little bit about your journey and how you kind of got into the pharmacy space?
Yeah, I was um, yeah, really weird background because my degree is in business. I've got an MBA, emphasis in marketing. Was doing marketing for a big oil company on their C store side of things. The convenience store brought pretty popular product into the market back in the day. This is going to really date me how old I am, but the Red Bull energy drink is a product that I got into the big oil company that I was doing merchandising for, and so that was a fun project and to see how popular that energy drink became. Before Red Bull, there's hundreds of energy drinks now, but back in those days there was only one other competitor in the marketplace called Hanson's Energy, and it had a nasty aftertaste. In fact, you don't ever see that. I haven't seen it. It may still be around, but I haven't seen it since. But Red Bull kind of took over that market for isotonic energy and adding vitamins and things like that. So now everybody's kind of jumped on that bandwagon with all the different kinds that you see out there. But yeah, that was a fun career. Right when I was about to take a promotion, move out to the headquarters in Chicago, a friend was doing a technology startup that looked really interesting to me, like a really fun project. So I co-founded a digital manipulation startup company, and it was a lot of fun for 4 years until the big Hollywood producers didn't like what we were doing with their artwork. Nothing was it wasn't illegal. We were putting layers over the top of the original
Hmm.
uh, MPEG for content, the video content, but the director still didn't like it. So we were turning swords into lightsabers, or we were, putting particle effects in, and catching people's hair on fire, and just different fun little overlays that would play along with the playback of the video. So
Hmm.
we're way ahead of our time. That was way before that's all being done today with AI. We were just doing it back before artificial intelligence, and my partners were game programmers, so they were really into all of the digital graphics and trying to make things look as lifelike as possible, and so that we were kind of incorporating some of that gaming technology into movie content, into back then DVDs. Your younger audience doesn't even know what a DVD is because everything's streamed today. But yeah, we were way ahead of our time. Had we come out with content like that in the last, 10 years, even the last 5 years, it probably would have just blown up and taken off. But we got sucked into a class action lawsuit with companies that were actually digitally changing the original, which is copyright infringement. And somehow we got lumped into that. Even though we were in the right to do what we did, we just didn't have the financial backing that these multi-billion-dollar studios had to fight it. So the technology got shelved. I needed a job, and one of the companies was actually looking at us for investment. They ended up hiring me, but it wasn't in the entertainment space. It was in the digital, still technology space, but now for online adjudication for claims. And I went to work for this company out of Memphis, Tennessee, relocated my family back there, and three became director of this company that was helping community pharmacies do revenue cycle management. So a third party payer. Prior to that company doing third party payments for community pharmacies, they kind of had to figure that on their own. They either had to have the patient pay for the medication and take the receipt back to their employer, or they had to
Right.
trust that they were going to get compensated for the medication they dispensed to the patient. So that
Hmm.
was all electronically processed now and done through a point-to-point adjudication through the pharmacy system, through a switch to the payer. So I was a part of that early on, that development. In fact, the technology platform wasn't even Windows based. It was kind of a DOS hybrid. You literally had to lasso things that you wanted to cut and paste and move them over. So it was pretty archaic, the platform that was developed on, but it was a solid platform and it worked. Community pharmacies loved it because we were able to help them streamline their workflow and get a guaranteed payment on those claims that they were dispensing,
Mhm.
mainly around the workers' compensation space. So, workers' comp's an interesting animal. It's an entitlement program. So, the patients know that they don't have a copay because their employer is responsible for covering their injury. And then the employers use Liberty Mutual, Travelers, other big carriers if they need that backing. And
Mhm.
so, but the patient knows they don't have a copay. So this streamlined that whole process, verified the claim was legitimate, compensable claim. It would help the pharmacies get their money faster, and would help the patient get their medication faster too, so that they weren't having to wait around for prior authorizations or anything like that. So pharmacies loved the program. They signed on. We had one competitor in the space, and eventually we bought that competitor. And so
Mhm.
all pharmacies were rolled up underneath this one provider of
Mhm.
this third party claims processing. Well, a big health system saw the opportunity to buy the company and roll it up underneath their pharmacy benefit management arm. So this big health system bought us. I didn't have any equity in the company, which was really sad because those that did made, millions of dollars. Um,
Mhm.
but that pretty much took that program, kind of took it to the dark side, because what we were doing was helping pharmacies get fair reimbursements. And now being a part of a pharmacy benefit manager, a PBM, the PBM was
Mhm.
going to make all the profit now and pay the pharmacy pennies.
Mhm.
I didn't sign up for that. I signed up to help community pharmacies, not to rob from them. And so
Mhm.
I left, and my going away present from that pharmacy benefit manager, that PBM, was a TRO, a temporary
Mhm.
restraining order. So, 3 days later, I get a knock on the door, and this sheriff deputy brings me this big stack of papers. I've been served, and it wasn't just process server. It was a sheriff that brought me this
Mhm.
stack of legal documents, basically a gag order to keep me quiet so I wouldn't
Mhm.
go tell all these community pharmacies that their 50, 60, $70 reimbursements were going to turn into $2 or $3, because that's exactly what the PBM just took all that profit, put it in their own pocket. So when the opportunity arose, there was a need for a true third party claims processor. And
Mhm.
so that's why I co-founded the ServRx program. So it took about 2 years to get out from underneath that TRO, settle that temporary restraining order,
Mhm.
and then relaunched the new and improved third-party program, which we call ServRx, and have continued to help community pharmacies get those fair reimbursements they deserve, and been doing that now for the last 11, 12 years. We've processed over $1 billion worth of claims. We are, contracted to help about 20,000 plus community pharmacies. We work with some of the large grocery store chains, but we'll probably never work with someone like CVS because they own their own PBM. So we're kind of the anti PBM processor. Wouldn't make sense for CVS to utilize us. Walgreens is another big chain that we don't currently work with today. But the big, large grocery store chains that recognize the names, are clients of ours, and then also the independents, the mom and pop community pharmacies. Which, by the way, a lot of them are really struggling now,
Mhm.
because the PBMs are just underpaying them for claims. In fact, about one-fourth of the medications dispensed at a community pharmacy actually walk out the door below their acquisition cost of the drug. So, in other words, it doesn't cover even the cost of the medication, let alone their overhead of their building, their utilities, their employees. And so that's why so many community pharmacies are just throwing their hands up, closing the doors. We've had over 3,000 pharmacies closed just in the last couple of years.
Wow. Wow. Now, Breck, can you give us a little bit more context of exactly when you talk about this middleman, this PBM, what exactly the biggest pain point that you solve, and how much money you're really saving these local pharmacies or even these bigger pharmacies.
Yeah, it's not a savings for them, it's a reimbursement. So the every state has established a state fee schedule of what they feel a fair reimbursement amount is for a particular medication. It's usually based off of the average wholesale price of the medication, or AWP. There are other forms of calculation. In California, you're going to have NADAC, and you're going to have WAC, and you're going to have MAC, and all these different, minimum allowable costs. But we base everything off of every medication has a particular NDC that's attached to it. So the strength, if it's a 250 milligrams, is going to have its own NDC, or national drug code, specific to that medication. And then the state sets up a fee schedule of what that medication should be reimbursed at. So the
Mhm.
payers, like Liberty Mutual and Travelers, they pay the same amount. They're going to pay the state fee schedule, whether we're submitting the bill or whether a big PBM like Optum, which is United Healthcare's program, or CVS Health, which used to be Caremark, but it's now CVS Health,
Yeah.
Express Scripts. Those are the three big pharmacy benefit managers: Express Scripts, Optum, and CVS Health. They control about 80% of the lives on the commercial or health care side. On the workers' comp side, there's a lot of self insured employer groups. So they only control about 75% of all of the lives, which is still a huge amount, right, between those three programs. Which, by the way, I might, your audience might want to know some of the statistics behind these big payers, like the
Mhm.
PBMs, the pharmacy benefit managers. The one pharmacy chain who also owns a PBM, they have 10,000 retail locations. They sell anything and everything that you can possibly think of in there. Makeup, they sell, chips and soda, and hair products. Not that I need any, but your hair looks great. They have all these things in there. And oh, by the way, in the back of the store is also a pharmacy where you can pick up a prescription too, right? Get your greeting cards, get your pictures printed there, everything, right? But then they also have a pharmacy in the back. Their PBM, even after having 10,000 retail locations, their PBM makes up about 75% of their total profit, not from the
That's huge.
pharmacy, not from the retail, but from the PBM just processing the claim.
Mhm.
United Healthcare has 65 million lives that they're collecting premiums on.
Mhm.
80% of their profit comes from the PBM side. Yeah. Very, very profitable for the PBM, not so much for everyone else in the chain, right? So back to your asking the difference here, or how this all works, is the payer is still going to pay that state fee schedule.
Mhm.
Okay. Even if the PBM gives them a discount, the average discount is only like 5%. So let's say the average wholesale price, AWP, let's just say it's 100% of AWP. Well, maybe that big employer group, if they're working with Optum or Express Scripts, they might get, where they only pay 95% of AWP for all those medications. But now the pharmacy is going to be contracted at minus 65% or minus 70% of AWP. And the PBM forces them to take that low reimbursement rate, and then the
Mhm.
PBM lives off that spread instead of paying the pharmacy, 70 or 80%, and the PBM making a small percentage. They're paying the PBM minus 65. They're keeping the difference between 95% and the minus 65. That's huge
Mhm.
spread. On most
Mhm.
medications, that's a good $50, $60 that they're putting in their own pocket. And the PBM doesn't even own the medication. They don't have own the pharmacy. They don't have any of the overhead costs. They're just processing the claim and keeping $60, paying the pharmacy $2 or $3. The one that
Mhm.
owns the medication has the overhead, is consulting with the patient to make sure the patient doesn't die by taking a medication that may, have a negative side effect, or be, not interact with another medication they're on. These pharmacists are keeping patients alive and getting $2 or $3, and the person just processing the claims making 60, there's a problem there. So our
Yeah.
model is much different. We bill at the fee schedule, whatever the state fee schedule allows. We expect to get paid at that, and then we pass that majority of that on to our pharmacy partners. So they're, in the case of a medication like meloxicam, that is, a 30-day supply of meloxicam, the PBMs are paying $4 and $5. Our reimbursement is over $90. Most states, it's over $100 for that
Hmm.
same patient. So do you take a $4 reimbursement or a $100 reimbursement if you're the pharmacy?
Yeah, I'm sure that's a no-brainer for a lot of them. So then where do you see the pharmacy industry going? Are we going to see eventually the kind of the death of PBMs where companies like your own, ServRx, are going to be used by every pharmacy? Or where's kind of in the industry going?
Yeah. Too many billions of dollars. If you ever, ever hear any kind of, there's some controversial thing that's going on, or there's this decision or that decision, what does someone say? Always follow the money, right?
Hmm.
Follow the money. So if you follow the money, there's too many billions of dollars at stake for PBMs to go away. Now,
Mm.
there is a big push and a big emphasis to reform PBMs to put them back to where they used to be back in the 60s when they first came to existence, to do the job that they were formed to do. And their job was to make sure that the right medication was being used for the right injury type or for the right condition. There was a formulary that would say these medications are to be used for this particular, issue, and they were to help to make sure to actually control costs. And now they're the number one reason that are driving up drug costs. So we need to make that 180-degree shift again, where they're actually helping the system and not hindering it. Private equity got involved. Big,
Hmm.
financing companies got involved. People saw all the money that could be made, and now they buy the way into situations that only benefit them, but under the false pretense that they're controlling costs.
Hmm.
So I can give you a couple of examples of that. The Department of Labor, big employer, right? It's all your federal employees. It's all your postal workers, all under the Department of Labor. So DOL is the workers' comp side of the federal employees. There was a PBM right here in Arizona, down in Tucson, that was doing a great job servicing that account for the Department of Labor. The company was called First Scripts. And First Script did a great job. We worked with First Scripts really well. We would manage a lot of the first fills before the patient even knew who their PBM was.
Hmm.
We would take care of the first fill. We had a lot of dispensing that was outside of the network of First Script. So we were taking care of all those patients, making sure they were getting their medication same day, no hassle, no delays. They could get, taken care of. We had a lot of podiatry offices, doctors that were working with these federal employees, like postal
Hmm.
workers that are walking these beats in these metropolitan cities, like Chicago. They're for 30 years, they've been walking this hard sidewalks and stepping up steps to go deliver mail for 30 years, and they wore out their feet and having, whatever problems they have with, that podiatrists have to take care of. But we were taking care of all those patients, making sure that they were getting the medications needed. Well, Optum really wanted that account. They wanted the book of business from the Department of Labor.
Hmm.
So when the Department of Labor goes out for a request for proposal, an RFP, they've got to do that every so many years, right, to give
Yeah.
other vendors an opportunity to bid for that service. So that's just, a federal requirement. They go out for request for proposal, RFP, and all the PBMs put in their bids. First Scripts is the incumbent, who we work really well with. They win the bid. Well, Optum sued, and that requires that the process stops. The federal government has to reopen the RFP. They go through the whole process again. First Scripts wins again.
Hmm.
Optum sues again, puts the stay in place, and then they come in and undercut the price of what they will pay for each medication. So therefore, the federal government looks at this and says, "Oh, if we go with Optum, we're going to save X millions of dollars per year because their price is lower than what First Script is charging per
Hmm.
medication." What the federal government didn't realize is that it was so priced so low that a community pharmacy cannot dispense the medication.
Mm.
So now they're going to have an access problem. But nonetheless, Upton wins the contract, doesn't allow my company, the third party processor, to help any of those pharmacies we were helping because it all has to go
Hmm.
through their bin, their processing. They won't even allow a third party. We were the only grandfathered third party with the Department of Labor, my company, ServRx. And they took that all away from us to supposedly give these patients better service. Well, their reimbursement to the pharmacy is minus 88% of AWP. So
Mm.
no community pharmacy can afford to lose, 88% of the fee schedule in order to dispense the medication. So who does that help? Only the big chains. The CVSs and Walgreens are probably the only ones that can afford to do that. Well, unfortunately,
Yeah, yeah,
there's not a CVS and Walgreens in every rural community, right? Only independents are in those rural communities. So now
yeah.
federal workers are having to travel an extra 30, 45 minutes to the next town over to get to a big chain that will fill their script for them. So hopefully there's enough pressure on the federal government in the next couple of years that when they go back out to RFP, they'll be a little more cautious about who they partner with. So that's just an example of how much leverage a big multi-billion dollar industry can have over
Hmm.
pushing their agenda. The other example I'm going to give you is right here in our home state of Arizona,
Hmm.
a ability that has been with physicians since the beginning of time.
Hmm.
Um, you're too young to remember Little House on the Prairie, but if you watch any old reruns or old episodes of Little House on the Prairie, if anyone got sick and someone had to ride into town to get the doctor, he'd come out and the
Hmm.
doctor would have his little black bag with him. Well, that little black bag wasn't just his, instruments, it was also the pharmacy. Okay.
Hmm.
Since the beginning of time, physicians have had the ability to dispense medications to their own patients. Okay.
Hmm.
When they do that, that was bypassing the PBMs. The PBMs weren't getting their pound of flesh. They weren't making their 50 or 60 or $70 per prescription off of a physician dispensing a medication directly to their patient. So PBMs
Hmm.
legislated for years and ServRx fought that legislation for years, but
Hmm.
was recently finally passed in the state of Arizona that now only a pharmacy can dispense the medication. So they took the right away from physicians, from doctors that have had that right since the beginning of time. They took that
Hmm.
away, not for safety reasons that they might, explain that that's the
Hmm.
reason why this needs to happen. It's purely financial. Follow the money. They were losing millions and millions of dollars in this state because they weren't able to get their greedy claws on those scripts that were being filled directly by doctors.
Wow, talk about leverage. You even said that, co-founding this company for the first 2 years, you had to battle that cease and desist that you were sent from your company you worked with way back then. Tell me, you know what I mean, the challenge of kind of working through that, and founding out the company and growing it to where it is today.
Yeah, yeah. Under that TRO, again, it was one of the big three PBMs that had their thumb on me to not be able to
Hmm.
help community pharmacies. So even though I needed to still provide for my family, right, and make a living, any pharmacy that I wanted to work with, I had to present that pharmacy to my attorney, who would then present that to the PBM's attorneys. They would always say, "Oh no, he can't work with that pharmacy. That pharmacy's in our network, and therefore he can't. Breck can't work with that pharmacy because they're in my network." Even though I knew the pharmacy had either canceled their contract with that PBM, or the PBM may have canceled their contract with that. But every time it was always the same. Because if you think about it, I'm this little startup company. This PBM has more, they have more lawyers in
Hmm.
one room of their big glass tower than I'll ever have employees. They have way more attorneys, so they're fighting every step of the way. So even though I would submit, hey, here's a pharmacy that doesn't work with that PBM, give me the permission to work with them, they would always push back and say, no, that pharmacy's in network. I would have to produce a cancellation
Mhm.
that no, that PBM had actually canceled the contract with that pharmacy before I could work with them. So it was just, they were doing everything they possibly could, not to just make it painful for me, but to absolutely make me just shrivel up and die and go away. Yeah.
So then how did kind of client acquisition work? How were you able to, eventually scale to, I believe on your site, 20,000 nationwide?
Yeah, after finally working through that TRO and having that settle after 2 years, then I went right back out to the community pharmacy industry and basically said, "Hey, open for business." And I went to a few key partners that I knew in the industry to get things started, some larger accounts, and then I went to the PSAOs, which are pharmacy service organizations that do the contracting for a lot of the independent pharmacies. I partnered with those PSAOs and contracted through them so that all their members got a blanket contract with ServRx, and then
Hmm.
all the member pharmacy had to do was just enroll with us. So even though we have a large under contract, the pharmacy still has to enroll. They still have to utilize us, and quite often the owner of the pharmacy may know the value of working, with ServRx, but their employee, their technicians are the ones in front of the patients. They're just trying to process the claim as quickly as they can to move on to the next claim, right? And so they may be accepting every PBM card that's handed to them, even if the pharmacy's not in network with that PBM. So it's kind of like, let's hurry and process this. What's the fastest way to get rid of this patient? And they just type in any bin or PCN, which is where the claim gets directed to, and now they're accepting a PBM reimbursement versus taking our reimbursement. So we have to make sure that we're constantly educating the technicians to so that they're not just accepting anything and everything. And from the owner standpoint, they understand, right? It's no different than if they accept a PBM reimbursement, they might as well just open up the till, take out $50 and light it on fire, because that's about the difference of what they're losing when they accept all of those carded programs. I know it seems a little 1980s, 1990s to produce mouse pads, but we actually produce these mouse pads that have our bin and PCN, the information on how to process to ServRx, and we get those out to the pharmacy technicians, so they're right there at their fingertips to help remind them, oh, hey, this is workers' comp, but let me process it to ServRx so we can make the higher reimbursement.
Yeah, no, that's awesome. And I guarantee it works, especially for
Yeah.
those lazy pharmacists. They're always on their computer, but you lift up your mouse and it's right there. Now, on the flip side of things, what's kind of been your biggest wins and your biggest successes in the field that make you proud, especially serving these small hometown pharmacies?
Yeah, I mean, obviously, we want to serve as many community pharmacies as we possibly can. Due to either monopolies or low state fund reimbursements, there are certain areas of the country that our program doesn't work really well in. So
Hmm.
just next door in California, it's a really hard state. Even though we have clients in all 50 states, we have patients in all 50 states. California is really a hard state for us to work in. There's these little closed networks that you have to belong to. We're 100% out of network. We're not affiliated with any PBM. We don't have any mail order fulfillment, so we're not robbing the patient away from the pharmacy to send them to a mail order pharmacy or anything like that. So there's certain areas where our program just isn't a good fit. Washington State has a monopoly there. It's the Washington Labor and Industry. Washington, Illinois, Montana, has the Montana Fund that is a monopoly. Ohio has the Ohio Bureau of Workers' Compensation. They control like 95% of the entire state population has to go through that programs. There's pocket areas where our program doesn't work real well, but there's for the majority of states, they would see a tremendous, increase in their reimbursement if they used ServRx.
Awesome. Now, looking ahead, we're almost done with the first quarter of the year. Is there any kind of top priorities on your guys' company to-do list, or any goals you guys are trying to meet by this year?
Yeah, we would like to expand our services to self-insured employers. So we do work with a few already. There's a big hospital system here in Arizona, Colorado, Wyoming, a big hospital that everyone would recognize. That we do their third party claims for their patients, but what happens when their own employee becomes a patient? So an example would be a nurse accidentally gets a needle stick. Well, if the glove gets torn or if they get a scratch, it doesn't even have to be fully injected, just a scratch on their skin. There's really, safe protocols that they need to go under for HIV, hepatitis, any kind of blood disease, and it's a very expensive drug therapy. Well, we do a straight pass through for that employer. It's that pharmacy employee at that pharmacy, and it's just whatever the cost of the medication. It saves that hospital system millions of dollars per year by doing that service for them. Well, we can expand that beyond this hospital system to a self-insured employer that doesn't even have pharmacies. And it's kind of like, Cuban's cost plus model. We would do whatever the cost of medication is plus a small admin fee, and it does save employers, anywhere between 20 to 30% on their pharmacy spend because we don't have that big margin that the PBMs are living off of. So it'd be like whatever the cost of the medication is plus a small admin fee rather than the cost of the medication plus a bill review fee and then another administrative fee and then this other hidden fee that makes it end up that the PBM is charging them, 50 or $60 more just so that they can make their spread.
Awesome. And to all the pharmacies that are not using, your services or using you guys, that are still kind of, in that PBM cycle, what is something that you'd wish to tell?
Yeah, they just need to get enrolled. They're probably already contracted through
Mhm.
their PSAO, so they just need to get enrolled so that we can help them. And then the other thing that I can help them with, so I also do a couple of podcasts for the industry. I host the PBM Reform podcast on the Pharmacy Podcast Network,
Mhm.
which is one of the most downloaded podcasts in the industry. And then I also do a community pharmacy more profit roundtable. And on the more profit roundtable, we identify other solutions, not just ServRx, but other solutions that bypass the PBMs to help pharmacies make and keep more profit. And one of the most popular things right now is a medical weight management. Community pharmacies are losing money on all of the GLPs that patients want. So GLP-1s are really popular, right? Everybody, Zempics and the Wegovy's and Manjeros and stuff, because they're losing weight and they're controlling
Mhm.
blood sugar, and there's a lot of benefits to this super drug that's come out. And so all these patients want it, but the pharmacies are losing money dispensing those brand names. Some are losing as much as $50 to $100 for per month. But they can't turn away the patient because the patient will just go to another pharmacy or they'll get it through mail order. So you've got the big mail orders like Hims, Hers, Row. We've all seen the advertisements for it, right? Well, they're poaching these patients away from community pharmacies. Well, there's a program that I just talked about now on my last podcast for the Community Pharmacy More Profit Roundtable that allows the community pharmacy to become their own Row or Hims or Her and manage it weight loss through their own pharmacy where they're not losing money on those GLP-1s anymore. In fact, they're making a profit of $60 or $70 per PMPM per member per month. And it's all supervised by a concierge doctor
Mhm.
and is less expensive for the patients than what even their copays are if it's covered by insurance. And not everyone's covered by insurance, so they're paying hundreds of dollars out of pocket if insurance isn't covering it. And this program is less expensive for the patient, plus the pharmacy is now making a fair reimbursement instead of it costing them money. So every pharmacy should look into that program as well. They can reach out to me directly, or they can just go to rxenhanced.com
Mhm.
for more information about that program.
Awesome. Good man. And Breck, if the audience wants to learn more about you and kind of see what you and the company is up to, where can they find you?
Yeah, easiest way to find me is on LinkedIn. There's no other Breck Rices in the world, and so they can just look up BRECK Rice. I do add my middle initial Breck L Rice, just so that when people are trying to spam me and use bots, I know that it's a bot and not a real person.
Well, all right, Bryce. It was, what I mean. I loved having you on today. A lot of good insight about, how do these hometown pharmacies can kind of step away from PBNs and help save instead of losing money. Actually, keeping more of that reimbursement they're getting. I thank you for joining us today.
Yeah, thanks for having me on.
Of course. All right, guys. See you in the next episode. All right, Breck.